So what exactly is an internuclear ophthalmoplegia? It's a fancy word, but a simple condition once you understand the basics. An INO is essentially a problem, as you can see, with ophthalmoplegia, which means a movement problem of the eyes. So there's a movement, an issue with the conjugate movement of the eyes rather, and it's a problem between two nuclei, internuclear. Which two nuclei? Well, let's find out. Let's say these are your two eyes, and this is the right eye, and this is the left eye. Okay, pretty weird looking eyes, but hey, let's go with it. So if I told you to look right, you want the right eye lateral rectus muscle to fire to make that right eye move right, and you want the left eye medial rectus to fire to look to the same direction. How do you get them both to look in the same direction? Well, to get that lateral rectus to fire, you go all the way to the nuclei of the lateral rectus, which is cranial nerve 6. Where does cranial nerve 6 live? It lives in the pons. And cranial nerve 6, when it basically fires to make that right lateral rectus fire. But then to make this medial rectus fire, you need input from cranial nerve 3. And that when that cranial nerve 3 on the left side fires, this is the right cranial nerve 6, and this is the left cranial nerve 3. When the cranial nerve 3 on the nucleus on the left side fires, then you get that medial rectus on the left side to fire as well. So that's already the internuclear component that we're talking about. But then how on earth are these two going to fire at the same time? Well, that's where you get a special structure that connects the two called the MLF. The medial, it's on the medial side, longitudinal fasciculus. Okay, fasciculus just means white matter tract talking to each other. So the right cranial nerve 6 nucleus talks to the left cranial nerve 3 nucleus via the left medial longitudinal fasciculus. And so if there's a lesion on that MLF on the left side, this right cranial nerve 6 is going to fire because the lesion hasn't affected the cranial nerve 6. So your eye is going to look to the right, but the signal to the left cranial nerve 3 is not going to come through. And so you won't be able to adduct on the left side. And because you can't adduct on the left side, the side that cannot adduct is the side where you name the INO. So a left INO is essentially a left adduction problem. But on top of that, what's going to happen now? Your brainstem centers are going to keep firing more because you're trying to look right, but it can't get that signal across because this MLF is broken. Essentially, it's damaged because of some other lesion. So the increased firing on that right cranial nerve 6 is going to keep making this lateral rectus fire and fire and fire, and so you get nystagmus and on the ipsilateral, on right gaze, on the abducting eye. And that's the reason you get that abduction nystagmus. So an INO, so let's say you get a left INO, it basically means you've got a left adduction deficit plus a right-sided abduction nystagmus, or a contralateral abduction nystagmus. So that's essentially in a nutshell what an INO is. Now, if you had to try and work out, is the lesion here or is the lesion here in the pons, how would you work that out? How would you know if the lesion is in the midbrain, if the INO lesion is in the midbrain, or if the INO lesion is closer to the pons? Because these are two separate structures. Well, then you look at another part of your clinical bedside arsenal called assessing a patient's convergence. In a nutshell, you're just going to ask the patient to look at their nose. So if you've got a patient and they've got a left INO, for example, and then you ask them, okay, so can you look at your nose? Where are the convergence centers found in your brain? Where are they found? They're found in the thalamus, or rather, more specifically, the thalamo-mesencephalic junction. It's basically where the thalamus connects to the midbrain. So already you've got the clue there. You've got a structure called the thalamo-mesencephalic junction, which is very close to the midbrain, and that is your convergence centers. So if you ask a patient to look at their nose and they cannot look at their nose, then the lesion must be in the midbrain. But if you ask them to look at their nose and they can look at their nose, well, then the lesion cannot be around the midbrain because it cannot be near the mesencephalic junction. So wherever the MLF lesion must be, it must be the MLF tract within the pons. And that's how you tell if an INO is caused by a lesion in the midbrain versus an INO caused by a lesion in the pons. So that's basically in a nutshell how you would tell what an internuclear ophthalmoplegia is, which direction is being impaired, or rather which specific MLF lesion is intact versus which is broken. And then you can take it a step further and ask yourself, is the lesion in the midbrain or is the lesion in the pons? That's to understand an INO.